So good evening and welcome all to this free paper presentation session of Young Professional Forum, jointly done with ISTM. I welcome you all on the behalf of the entire team of Young Professional Forum. We are a group of dedicated individuals, namely Dr. Mohammad Abu Bakr Rafi, Dr. Ankit Mathur, Dr. Rizwan Javed, Dr. Suvro Datta, Dr. Puneet Jain, and myself. We are meeting today for the free paper presentation. This is the second free paper presentation of this academic initiative. We'll be uh, joined by the very eminent speakers who are the young budding residents of transfusion medicine. We are joined by the legends of transfusion medicine as our chairpersons. It is an honor and a privilege to introduce Dr. Jayashree Sharma. Ma'am is Professor and Head, Department of Transfusion Medicine, SAIT GS Medical College and KEM Hospital, Mumbai. Ma'am has more than 30 years of teaching experience. She is member of Governing Council and Technical Expert of SBTC Maharashtra State. She has pioneered the MD course in transfusion medicine in 2010. She also took the initiative in getting NABH accreditation of the blood bank in 2012 and re-accreditation continued till 2022. We welcome you, ma'am. We would request you to say a few words before we go further. Ma'am, you're muted.
Thank you so much, Dr. Aikach, for all the nice words which you have spoken for me. Actually, you people are the pioneers and the future stars and future, whatever, you are our future for the field of transfusion medicine. You are taking it forward. And in fact, I'm so happy that you have taken this initiative of starting all this young professional forum and starting all the academic programs and all the teaching sessions, which is the need of the hour in the present times, present situation. At the right time, right moment, you have taken the right and the apt attitude and the apt approach you have taken. I'm really very happy for this. And thank you so much for giving me this opportunity to be amongst you all and to guide you all. And it's my proud privilege and honor. Thank you so much, Anarkar. I have no words, and in fact, I can go on and on,
Thank you, ma'am. The honor is all ours. It's again an honor for us to have Dr. Nidhi Bhatnagar amongst us as a chairperson. Ma'am is Associate Professor and in charge, Department of Transfusion Medicine, BJ Medical College, Ahmedabad. She's a pioneer in the field of in the field of transfusion medicine in Gujarat, and she has established a separate department in 2004 in BJ Medical College, Ahmedabad. That was the first ever separate department of transfusion medicine in Gujarat. Ma'am is instrumental in getting accreditation as quality manager in Department of IHBT Civil Hospital, Ahmedabad, which was the first blood bank in the government sector in India to be accredited by NABH. I think this feat alone requires a standing ovation. Ma'am is lead assessor for blood banks for NABH, Quality Council of India, and has assessed more than 30 blood banks across India. Ma'am has been invited as speaker in national conferences and presented papers in national and international conferences. She also has in her kitty a reviewer for many national and international journals. Ma'am is also reviewer of abstracts submitted to ISBT congresses. The publications are numerous for Dr. Nidhi Bhatnagar, both in international and national journals. Ma'am has also been instrumental in organizing a number of workshops for rational use of blood and components for residents and faculty of civil hospital, as well as conducted a number of training programs for the blood bank medical officers and technicians, nursing staff, counselors, drug inspectors. I think it is needless to say, ma'am is an asset to all the organizations she's a member of. And those organizations are, I think, all the organizations of transfusion medicine. It's an honor and a privilege to have you amongst us, ma'am.
Thank you so much, Aikaj. Just one sentence I would like to say. First of all, thank you for inviting me as a chairperson and all the nice words you have told about me. And as Dr. Jayashree Madam has already told, I would like to add. I agree totally to that, and I would add one more thing is that this was the need of the hour, and which you have picked out very nicely, and you have realized, and this is the need of the hour right now, and what we all are doing it, and in fact this is the way we are connected and we are learning. Every day is a learning process for all of us, we too. So it is my honor and privilege that if I can be of any help or any, I can put my inputs over here. But frankly speaking, it is always a learning process for the both the parties. Whenever I go for NaBH assessment in a blood bank, it is a learning process for me, and then I come back and then implement in my own blood bank. And one last word I would like to say is that you are the Dhruv Tara of transfusion medicine. And so I'm sure you're going to take it much more far and bright, as it is the brightest star. You're the Dhruv Tara. Thank you so
Thank you,
much.
ma'am. In the same breath, I would say, rather than me being alone, we are a constellation
Hmm.
of Rafi, Ankit, sir, Dr. Rizwan, Dr. Suvru, Dr. Puneet Jan. It's like fingers of the same hand. And in the same breath, I would hand over the mic to Dr. Rafi to please take it forward. Dr. Rafi, over to you.
Yeah, welcome, chairpersons, and thank you, Aikaj. Now we'll be going to the second edition of free paper presentation. We'll be having three participants. That is one Dr. Pooja Veturi, JR3. She's from Kamineni Institute of Medical Sciences. She'll be talking on rational use of packed red blood cells in a tertiary care center. After that, we'll be having Dr. Anju Kurup. She's JR2 from AIMS Rishikesh. She'll be talking on impact of COVID-19 pandemic on blood transfusion services at AIMS Rishikesh. And the third speaker would be Dr. Amarnath Pandey. He's JR3 from AIMS Rishikesh itself. He'll be talking on adverse transfusion reactions, a retrospective analysis at AIMS Rishikesh. As we have decided, we'll be having 15 minutes for each person to talk, after which we'll be having a discussion as decided by the chairpersons. And next slide, please. And we are also planning to send out certificates. There are certain criteria, like we won't be sharing the link outside this chat, so it's only available during the live session from 3:30 to maximum at 5 p.m. Please do fill the details, like your name especially, as you require in the certificate, and it will be automatically used. Whatever you are entering, it is automatically used, and the certificates will be dispatched as email prior to the next YPF meet. I would also like to say that all our presentations have been recorded and are also available in the YouTube channel which we have recently started, and all over to our chairpersons to take it forward. And I would like to invite Dr. Pooja for her first presentation.
Before we just start with Dr. Pooja, I would also like to extend a very warm welcome to the head of the Department of AIMS Rishikesh, Dr. Geeta Negi. Ma'am has encouraged her residents to participate wholeheartedly in this academic event, making it a success. We thank you from the bottom of our hearts, ma'am. Thank you so much for your continued support and encouragement.
Thank you, Aikaj. Thank you for giving my residents a chance. Thank you.
Over to Dr. Pooja.
Pooja, you can start sharing your screen.
Yes, sir. Is it visible, sir?
Yeah, you
Yes.
can make it full screen.
Good afternoon, everyone. This is Dr. Pooja Vituri, third year junior resident from Department of Transfusion Medicine, Kamineni Institute of Medical Sciences. First and foremost, I'd like to thank the organizers of Young Professional Forum for giving me the opportunity to present my scientific work on rational use of packed red blood cells in a tertiary care setup. Transfusion of blood components is an important therapeutic resource even today in 21st century. Due to effective screening procedures and regulations, transfusion of components has though achieved reasonably high levels of safety, yet there are significant potential risks involved even today. And it has been estimated that between 5 and 58% of transfusions are unnecessary. The main purpose of transfusion of packed cells is to prevent anemia-related tissue hypoxia, and it is employed to achieve this goal in conditions where the causal treatment of anemia is either not feasible or is inadequate. Although there are various alternatives to blood transfusion, yet there is no real substitute for blood. And except for emergencies and urgent indications, anemia should be ideally diagnosed and treated before any elective surgery. So transfusion trigger is the hemoglobin concentration at which the administration of packed cells is initiated. And there are numerous studies that have concluded that a restrictive transfusion strategy with transfusion threshold at hemoglobin 7 gram per dl is not inferior to a liberal strategy with higher thresholds at 10 gram per dl. And it has also been concluded that in cases of young patients and critically ill patients, the restrictive strategies are rather superior and are associated with less adverse outcomes. Which are data on clinical use of packed red blood cell, especially for the Indian subcontinent. So the goal of this study was to determine the appropriate clinical use of packed red blood cells in various departments in our hospital and to utilize this data for improving the transfusion practices. So this was a prospective observational study which was conducted in our hospital from November 2019 to March 2020 and was approved by the Institutional Ethical Committee. The source of data were the cross-match requisition forms, the hospital information system, the inpatient registers, and case sheets of the patients who received packed cell transfusions. All the patients admitted in the inpatient ward of our hospital and who received the packed cell transfusion and for whom the pre and post transfusion lab parameters were available were included in the study. As for the exclusion criteria, patients for whom relevant clinical data could not be collected, patients who did not have pre-transfusion and post-transfusion parameters, and known cases of chronic kidney disease on maintenance hemodialysis, and also the pediatric cases were excluded from this study. Coming to the methodology, at the blood bank, the cross-match requisition forms were screened for age and gender, requesting department, provisional diagnosis, indication of transfusion, the number of units issued, and also most importantly, the pre-transfusion hemoglobin was documented. Bedside monitoring was done, transfusion rounds were done, and the evaluation of the clinical condition was done. Post-transfusion hemoglobin from the case sheets or the inpatient registers were documented, and the appropriateness of the transfusion was assessed by a predetermined criteria, which was based on the developed based on the guidelines for clinical use of red cell transfusion. So this is the predetermined criteria that was utilized. So if a patient had hemoglobin less than 7 gram per dl, or if the patient had hemoglobin less than or equal to 8 gram per dl in elderly patient population, that is more than or equal to 60 years of the age, or also in patients who were reported for pre-anesthetic checkup clearance, if they had hemoglobin less than 8 gram per dl, then a transfusion in such situations was considered as appropriate. If this criteria was not met, then it was considered as inappropriate. As for patients who had hemoglobin more than 7 gram per dl, a transfusion was categorized as appropriate if only he or she had signs and symptoms of anemia such as fatigue, shortness of breath, tachycardia, etc. Or if the patient had any pre-existing comorbidity or any cardiovascular disease, cerebrovascular disease, etc. Or if the patient had any intraoperative acute blood loss, obstetric hemorrhage, or any ongoing active bleeding in the postoperative period, any hemolysis or bone marrow failure. So if these criteria were not met, the transfusion was categorized as inappropriate. And if met, they were categorized as appropriate. So coming to results, we observed that there was a female preponderance among the transfusion recipients in our study, with almost 62% being females. This probably reflects that this being a rural area and women usually in their reproductive age group are usually anemic. So that could be the reason for higher percentage of female recipients. Coming to the age-wise distribution of patients, the maximum number of patients were in the age group of 46 to 60, followed by in the age group of 15 to 30. So various indications for which Paxil was requested was broadly categorized into 4 categories: anemia, perioperative indications, traumatic blood losses, and obstetric hemorrhage. As we can see over here that almost 49% of patients were transfused in view of anemia, and of this 39% of patients were transfused appropriately. So this also justifies the main goal which I had told in the introduction, that the most common reason why patients are usually transfused is because of to correct the anemia. So these 39% of patients were transfused because either their hemoglobin was less than 7 gram per DL, or they were elderly patient population with signs and symptoms of anemia. And for these 10% patients who were transfused inappropriately, although they had moderate anemia, but they were clinically stable. And the clinician probably transfused thinking that it would be beneficial for the patient or improve the quality of life. The next indication was perioperative, which is also a very high percentage of patients being transfused in view of the in the perioperative period. So of this, 34% of the patients during transfused in the perioperative period received appropriate transfusions, either because of the active blood loss in the postoperative phase, or the intraoperative hemorrhage which exceeded the maximum allowable blood loss, or either they had the hemoglobin less than 8 gram, which prevented them from having their PACs cleared prior to OT. And the 8.7% of the patients who received inappropriate transfusions, this was probably because the surgeons felt the need to transfuse in the postoperative phase because of their orthodox thought process of that it could be beneficial for the patient, as anemia is usually considered as a independent risk factor for postoperative morbidity. Also, some of them were transfused preoperatively because they were being posted for OT in the near future, and the surgeons thought that they estimated the blood losses to be excess. So these were the possible reasons for the excessive inappropriate transfusions in the perioperative period. So total PRBC unit transfusions during the course of admission, it was observed that almost 28% of patients received single unit transfusions during their course of admission, while 36% patients received 2 units, and more than or equal to 3 units were also given in almost 36% of patients. So this is the patient distribution across departments. And as we can see here, that 113 patients were transfused in the orthopedics. And this was followed by the patients being maximum in number in the Department of Obstetrics, and this was followed by general surgery. So we can see that there was a relatively higher percentage of patients being transfused Paxils in the surgical departments in comparison to the medical departments. This is possibly because the perioperative percentage of perioperative indications are very high in this present study. And also, even in the patients who are transfused in the perioperative period, they also sometimes have pre-existing anemia. So anemia and perioperative indications are quite high over here. So although the surgical patients received maximum number of transfusions, what is to be noted over here is that the patients in the emergency medicine received maximum appropriate transfusion, which is almost 95%. And this was followed by patients of the from the Department of General Medicine, where the percentage of appropriate transfusion was as high as 89.3%. And patients in the ENT department, though were least in number, but had maximum number of inappropriate transfusions, which was 66.6%. So in this study, 436 patients were evaluated for a total of 710 transfusions that they received. A predetermined criteria was set to analyze the appropriateness of transfusion in contrast to the older studies where only hemoglobin thresholds were used for evaluation. 81% of the transfusions were appropriate, while 19% were inappropriate. The mean pre-transfusion hemoglobin was noted to be 7.58 gram per DL. Mean post-transfusion hemoglobin was observed to be 9.65 gram per DL, and the mean increment in hemoglobin was 2 grams per DL. Coming to discussion, various studies have been performed assessing the utilization of this appropriate utilization of Paxil. As we can see, a study by Moses B et al., then a study conducted in 1999, and a very recent study published in the year 2020, and also a North Indian study in 2015 have shown the percentages of appropriate transfusion to be in the range of 50 to 65%. So this percentage is quite less in comparison to the findings of the present study, which is wherein the percentage of appropriate transfusion is almost 81%. Also, in contrast to the studies conducted by another South Indian study conducted by Gomti et al. In 2012 and another study by Tiwari et al., we can see that the percentages is even higher, which is 90% and 90.2% respectively. So the possible differences in these percentages is because some of the studies have utilized only the hemoglobin or hematocrit parameters to evaluate the appropriateness of transfusion, and some studies though have utilized the criterias and fixed set of clinical condition wherein the patients are transfused, yet it is not very strict. As for these studies where the percentages are higher, it is they have basically utilized not just hemoglobin as it is a surrogate marker, but they have also made use of certain algorithms and stringent criteria to evaluate their appropriateness of transfusions. So it must be borne in mind that although we are promoting restrictive strategies, we must not just adhere to the hemoglobin triggers to evaluate or assess our transfusions in our hospital, because the triggers are changing, and numerous studies are coming up wherein they are asking the institutions or the clinicians to set triggers for various clinical conditions. Like for instance, in critical care patients, it has been postulated that it is better to set it restrictively. But again, when it comes to patients of hemato-oncology departments or patients who have respiratory distress admitted in the pulmonology department, they are concluding that it is better to transfuse such patients liberally rather than strictly adhering to restrictive strategies. So the criteria base having a study with a predetermined criteria and algorithms is an advantageous thing, because we will not just evaluate the patient based on their hemoglobin or hematocrit parameter, and instead evaluate the clinical condition of the patient in totality, and this will give us a higher percentage of appropriate transfusions. So I'd like to conclude by expressing my heartfelt gratitude to Dr. S. Venkat, who is the Associate Professor of Department of Transfusion Medicine, for his encouragement and guidance. And these are my references. Thank you.
It's open to the chairpersons for the discussion.
Yeah, so Dr. Pooja, it was a very nice presentation and a nice study of audit you have taken up. And I think, as in your introductory slide, you mentioned that not many studies have been conducted and published. What I feel is that these are the studies, even when it comes to when it comes to me as a reviewer, these are some of the studies where or articles or papers which we sort of because it's an audit, we tend to sort of and not an actual interventional study, we tend to ignore it, and we tend to sort of push it aside. It happens, it is natural. But I think more such audits need to be published. And what I would one question for you is that predetermined criteria. What was the basis for this predetermined criteria which you mentioned? We do not have any Indian guidelines which that trigger, the transfusion trigger for HB, we do not have. So what
Um,
was your basis? Was it the British guidelines or the American or the European? Which were the ones which you took as the basis for these predetermined criteria?
Yes, ma'am, you rightly pointed that we don't have Indian guidelines. So we took up an amalgamation of couple of guidelines. So the AABB guidelines published in 2016, also the NICE guidelines published in 2015, and the BCSH guidelines. So we tried to take up the whatever possible guidelines were available. Also the WHO guidelines for clinical use of red cell transfusions. So all the criteria that was given in these various guidelines, we tried to come up with a common criteria because as in the ABB, they have not mentioned the correct criteria for oncology cases, but it has been given in BCSH. So accordingly, we have seen wherever a certain criteria that, also to make sure what patient population we are tending to. So the hemato-oncology cases, we don't have too many hem-onc cases in our setup, because this is not serving to that kind of patients. So we had to ignore the criteria or trigger for such patients. But we have a lot of perioperative transfusions that take place. So accordingly, we made use of all four criteria, four guidelines.
So it was overall, according to me, was a nice presentation. But one suggestion is that you could have added in the summary or conclusion, you could have added that we need to have our own guidelines based on Indian data.
Yes, ma'am, that is.
Over to Jayashree, madam.
Very nice presentation, Dr. Pooja.
Thank you, ma'am.
You have explained everything well. Only 2-3 points I wanted to tell you regarding your presentation. That is, you are a little fast, I think, you should be a little slow in explaining. You are going to, the train was too fast, it was like that. So try to be a little, the speed should be less, your speed of talking. Then second thing is that the results which you have projected, that results, along with the results, some one line about interpretation would have been better, Whenever you flash the results, side may just put one or two lines of interpretation also. So along with your explanation, that this thing also is seen clearly and vividly, and you did not explain too much also, and the time goes in that, because whenever you go for this thing, webinars or conferences, time limit is there. So for that, you can cut down on that. Just try the interpretation also along with that. Then thirdly, in discussion part, you have mentioned only the references of other studies and other authors. So actually, along with that, you should mention whether your study is similar to that, or you are differing from the other studies. So that is always there in discussion part. Whenever you quote other studies, along with that, your own study comparison is there. So that would have been better if that would have been written. Then lastly, some take-home message is always there. Whenever you conduct any study, you give some take-home message, or and give some guidelines or suggest some guidelines. Now you have done such an extensive study, so you have to give some guideline to people, or suggest some guideline, or say that we have to, in our scenario, the condition is like this, like that. So these are the things which I wanted to say. Otherwise, your presentation has been very well, Pooja. Congratulations.
Thank you, ma'am. Thank you.
We have some questions from the chat box to Dr. Pooja. Single unit transfusion is very high. What the blood bank is doing to reduce the single unit transfusion? That is from Dr. Bharat Singh, sir.
So yes, sir. I think there was 28% or something was the single unit transfusions. So ideally, what I feel is there are a couple of studies where they have stated that we must not encourage single unit transfusions. But also the Australian Red Cross Society recommends that it is better to transfuse a single unit and then evaluate the patient to see how the clinical condition is, rather than giving multiple units at the same time. So we are not really working on to reduce the single unit transfusions, because sometimes one unit is indeed required, and instead of promoting that we will not give transfusions at all, because that kind of creates unnecessary tension among clinicians, because they usually feel that transfusion is required in certain cases, like for instance the perioperative cases where single unit was required for a PAC clearance, because that is the hospital protocol, that they are not given the PAC clearance, and which is also justified. And also same is the post-operative phase when a patient is bleeding, and a single unit transfusion may be justified and necessary in particular cases. So we are not really working on reducing such units unless they are completely unnecessary.
There are two more questions. I'm clubbing it due to paucity of time. You'll have to answer it also very fast. What were the number of patients totally enrolled, and is there any particular reason for high fraction of inappropriate transfusion in ENT?
So the total number of patients I've already told is 436. ENT, they had least number of patients, but the percentage is high because, say, the post-operative phase, even if there was a little amount of blood loss, the surgeons felt that it is advisable to transfuse such units. So that is the surgeons or the Department of ENT protocol, that they make sure that they transfuse if and reserve units if when they are posted for surgery.
Dr. Pooja, my question, can I take 1 minute, Dr. Rafi, if I'm audible?
Yeah, go ahead.
Yeah, so your sample size was 436 for completer analysis because you told that you have exclusion criteria also. So my question was, how many patients did you enroll actually, then how many were excluded, and then finally you have taken up 436 as final analysis? Okay, because if so many exclusion, then you may have patient selection criteria bias when you are analyzing your results.
So patients who are coming for hemodialysis, maintenance hemodialysis, and are receiving transfusions, they were anyways excluded because that is something daycare dialysis. They come for daycare dialysis, and usually they do not have their post-operative hemoglobins documented. So we did not include those cases at all in the study.
Okay, because your
So
methodology says that you have exclusion criteria, then you might have included, it was a prospective study. So exclusion will happen at the end of when you are doing result analysis, not at the beginning.
yes, sir, you're right. So by that logic, there were total number of transfusions in that period were actually more than 1,000. The patients who were evaluated were more than 1,000. But because I'm presenting this only in the result aspect, I had directly mentioned the total number of patients who were actually included in this study.
Yeah, I got it. Just a advice for you. So you
Okay,
are
okay, sir.
saying more than 50% were excluded. So
Okay,
somewhere
like
study
due to
methodology you
paucity of
need to improve.
time, I
Yeah,
think we'll
can
have to go
continue.
ahead. Chairpersons, can we go ahead for the next person?
Yes, please.
Yes.
Okay. Yeah, Dr. Anju, can you start sharing your screen?
कुछ मत कर, don't do anything.
Sure.
वो लोग चालू कर रहा है, वो लोग
Yeah, just minimize that slide and or open your PPT. Yeah, and make it full screen, please.
Sir, am I audible?
Yeah, audible and visible. Go ahead. Tap on the first screen, then your next slide will come on. Just tap on the first front screen using your mouse, and you can, yeah. Go ahead. We can't hear you now. Have you started speaking? Dr. Anju,
Yes. Yes.
we have, yeah, go ahead.
So today I'll be presenting on the topic impact of COVID-19 pandemic on blood transfusion services at AIIMS Rishikesh. And I will be covering the presentation under the following headings. So on December 31st, 2019, there was an outbreak of pneumonia, which was reported in the city of Wuhan in Hubei province in People's Republic of China. And on 7th January, it was identified as the severe acute respiratory syndrome coronavirus 2, the SARS-CoV-2. So this novel coronavirus disease, as we all know, is a highly contagious respiratory disease caused by the SARS-CoV-2 virus. And WHO has declared it as a pandemic. So by the end of March 2020, there were 0.46 million cases which have been recorded worldwide with a high mortality rate. And as per WHO data, by November 2020, the cases have gone up to 46 million with 1.2 million deaths reported globally. So there were a lot of challenges which the blood transfusion services face, which include the blood donation, that is the recruitment of the healthy blood donors and their follow-up, the inventory management, the staff safety and the adequacy for emergency work, and the consumable management. So to prevent the community spread of the SARS-CoV-2 virus, the government of India had announced a national lockdown in March, which affected the blood transfusion system. So the pandemic has affected the blood transfusion services from blood donor shortage to increased wastage of blood components. So this is a graph which compares the 2019 and 2020 data of the total donation which happened at AIIMS Rishikesh. Here we can see that there has been a drastic decrease in the number of donation which happened after the lockdown, that is from March to June, and even now the trend is continuing the same. It has not picked up like last year. And here we can see the in-house voluntary and the camp the data of 2019 and 20. Here also we can see that the number of camps have decreased drastically, and whatever we had during the April, May, June, those many months, the camps have been mainly the in-house as well as the mobile blood bank which we had opened up. So coming to the PRBC request and the issues, here I have compiled the data of 1 year from October 2019 to September 2020. Here we can see that the number of requests have come down during the months of April, May, June, July, and the trend is continuing compared to last year. The same has been happening with the RDP request and the issues. Here also in April, May, June, and July, the number of requests and RDP issued were less. Even the trend is continuing. It's not the same like last year. And coming to the FFP, here also during April, May, June, July months, the number of FFP requests have come down and the issue has also been the same. And coming to the cryoprecipitate request and the issue, comparing the last 1 year data, the cryoprecipitate request had shown a different scenario. Here, there were less number of requests from March onwards, but by May, the number of requests and the issue had been picking up. This is mainly because our hematology department, which was working throughout, even during the pandemic, but the number of patients have increased more after April, and from May onwards, the cryoprecipitate requests and the issues have been increasing. And comparing the data of 2019 and 2020 regarding the PRBC stock and the wastage, here we can see that the preparation had been less compared to last year. Also, the issue had been, it can be compared, and discard rate has not been that much. Also RDP, but the case is different here because of the expiry of RDP units. The number of wastages have been more compared to last year. The FFP stock and wastage comparing 2019 and 2020. Here we can see that during the months of April, May, June, the number of units prepared, the FFP prepared were less. The issue was also less, and the number of units sent for fractionation was also less compared to last year. So now coming to the discussion part, here I have shown a picture which shows this is the point. The first picture shows the point of entry of the donors, and we had created a makeshift reception kind of place so that there is and security guards were assigned. So this is what we have done here is the donors were screened at this entry point, and the guards made sure that they wear the mask and sanitize their hands and keep a distance from each other. So, and also entry of unauthorized persons in the blood area were restricted. So this is the second picture we see is the donor waiting area. So the donor area were sanitized at frequent intervals, and donor couches were placed at a safe distance of 1 meter. So this has been the some of the measures which we had taken during the COVID times. And now comes a lot of challenges have come because of the pandemic. The first was the challenge what we faced was in blood donation. There was obviously there was a significant reduction in the blood donation. So that is basically because the healthy population, they had the fear that they might get infected while visiting high risk areas like hospitals and also during travel. So there was possibility of asymptomatic or infection in donors, and false history of exposure further leads to risk of infection. So also we were unable to conduct any large number of camps, voluntary blood donation camps, because of the risk of community spread, and also because of the prohibition of mass gatherings by the government. But we had a good number of voluntary camp organizers who were helpful, and the donors were recruited by them to our blood bank. So also we had conducted small in-house camps, and also we have encouraged regular repeat voluntary blood donors to donate. And also here we can see we have conducted camps which were, I mean, the donors were comparatively less, but we had kept all the precautions. Also, we had conducted in-house blood donation camps, and we had mobilized our staff and students and residents who were willing to help us during this crisis. And this is the donor passes we had given to the donors, so that they could travel without any problems. And also the mobile blood bank has been started, which was placed next to the hospital gate, so that the donors need not fear entry into the hospital premises. So also, next challenge we faced was in the blood stock inventory. So in response to the shutdown of regular OPD services and routine surgeries, there was sudden decrease in the demand for blood and blood components, and wastage was a major issue because of short lifespan of certain components, and also like requirement of fresh components for patients like neonates. And there was limited transfusion because of the fear of transfusion transmissibility of SARS-CoV-2. So we had maintained a proper inventory to reduce wastage. And during early stages of the pandemic, when the population was relatively unaffected, we tried to boost our blood stock for because we were anticipating a shortage later. So we followed the FIFO policy, that is the first in, first out, after verifying the inventory physically. So the clinicians were also motivated to use non-identical but group compatible blood components in place of identical groups, and also like specific components like single donor apheresis platelets. Those were prepared. Those were helpful in case of shortage of platelet concentrates. Also, the clinicians were made aware of the scarcity of the blood during this pandemic, and we had sensitized them regarding the use of transfusion alternatives like albumin, iron, erythropoietin, etc. The next challenge we faced was the consumables and the equipments. So this nationwide lockdown and banning of these flights and other means of transport, that led to a cut in the supply of all consumables, essential consumables required at our blood center. So also there were lesser number of sample, which was there were lesser number of due to decreased workload, the samples processed were less. But our automated equipments, which needs daily maintenance, so there was lots of wastage of reagents. So what we did was, so due to this logistic issues and because of all these challenges, what we decided to shift to the manual testing. And with the help of higher authorities, hospital authorities, we tried to procure them through special means. And also we started testing the COVID samples in batches. Then also the suppliers were advised to be ready with more consumables if there is because we were expecting a rise in the workload at the end of the pandemic. But with all this, the other patient services continued to be unaffected. Like we were continuing our procedures like therapeutic phlebotomy, therapeutic plasma exchange. We were using personal protective equipments, and we were willing to serve. The staff challenges, this is one of the most important, because we had the responsibility of keeping our staff safe from infection, and we had to maintain adequate manpower for emergency work. So what we did was, they were motivated and staff education was given, and we had staff rotation, that is in batches, to reduce the exposure. And any staff member or the family members were found to be symptomatic, quarantine was advised. Initially there was a shortage of personal protective equipments initially during the pandemic. So that had affected the manpower and the confidence to work. So there were also irrational use of the PPEs. So what we did was, we assigned separate dedicated staff for transfusion related testing in COVID-19 patients. And the samples were processed under laminar airflow or biosafety cabinet. So this is the first picture here we see this is a reception area, which we had provided a barrier so that the reception staff can have a communication with the patient's attendant, but there is no direct contact. Also the biosafety cabinet, which was given to which was being used. And apart from all the work that has been happening in our blood bank, the academics were initially affected. Our academic activity was initially interrupted, but but we found solution assessment using apps like Class Marker for the residents. And it's my maybe perhaps first in India. I think it's our institute which we had conducted MD examination through online. Also, the thesis going batch were also like initially they were affected, but later on because of better communication through emails, and we could overcome that. And there were a lot of low level of motivation and feeling of anxiety among the doctors as well as the staff. So for them, what we found was we made a lot of multilingual awareness and motivational videos, online poster and slogan competitions, etc., so that we could boost their, we could motivate them more. And next slide, this is a video which we had prepared. And
I think there is no audio. Like video is seen. No issues. Go ahead.
last but not the least, most talked about convalescent plasma. So though it has many studies have been conducted for the convalescent plasma, and it is in an experimental therapy which suppresses the viremia and shortens the hospital stay, the lowest mortality, especially in the initial, if it is given in the initial stages. So the influx of COVID positive patients happened quite late in our institute compared to rest of India. So we started our convalescent plasma therapy in August 2020, and till now we have issued 110 units to our patients. So, concluding, I would say that COVID-19 has deepened the gaps in India's blood donation and transfusion services. Though it had a negative impact on blood donation, the overall blood transfusion services were well maintained due to the rigorous safety precautions we took against the COVID-19 pandemic, good communication strategies between the blood bank staff, the suppliers, clinicians, donors, and the public. And last but not the least, it's collaborative efforts of, because healthcare is a teamwork. So it is a collaborative efforts of transfusion services, clinical services, hospital authorities, blood donors, and social workers. With all this, we could overcome this pandemic. These are my references.
It's open for
Thank you.
discussion for the chairpersons.
Yeah, very nice presentation, Dr. Pooja, Dr. Anju.
Thank you, ma'am.
Yeah, very nicely done. I think it was the same story, and many of us in the working in the blood banks across India who have joined today would agree with whatever you have told today. Just one point I wanted to add was that at these times there was a lot of training required, as you have also done in your blood bank. Blood center, but a lot of training was required for our own in-house training for our own staff, mainly the class 4, regarding the biomedical waste disposal, and also the new NACO guidelines, which were, at the times of the corona, how the donor is to be screened. So those had to be, percolated into our own staff. So that is one point which I think you missed out. Otherwise, it was a nice presentation. Thank you.
Thank you, ma'am.
Jayashree, madam.
Yeah. Dr. Anju.
Yes, ma'am.
Very good presentation, very nice presentation, and you have covered almost all the aspects which is being faced by everyone. Whatever you have faced, we all have faced the same. But one thing, I mean, there was a lot of apprehension among the staff, especially as government setup, of this staff, they get very scared, and they refuse to touch COVID samples, and all those initial problems we all must have had, But after overcoming all that, and you have done it very beautifully, how you have shown stepwise how you right in the beginning how it was there, then how you improved from there, how you have improvised, and finally how you manage the blood transfusion services. So you have explained it very beautifully. The
Thank you, ma'am.
faced was that COVID samples people were refusing to touch. Technicians were very scared. So there lot of counseling was required for our own staff as to how to manage the samples. I mean, you have to give blood to the COVID patient. You cannot refuse, saying that it's COVID, you won't touch. So some basic precautions we had put it up for the staff, like no centrifugation. You create a separate work area only for COVID samples, and giving them courage and all that, that we did. And secondly, even we had this, camps were affected. Indoor our collection was also affected. In fact, we had around up to 550 patients, COVID patients were admitted. So really it was a very tough time, but I know we all have to manage. There is no this thing to, I mean, no excuse for us. We have to manage somehow. So what was our observation is that in camps people were more like comfortable to donate than coming indoor, because hospital premises may they are scared to donate, whereas in outdoor camps they have some faith. So like it is like that. Any this thing, some query was there?
Yeah, in the chat box there is one question. I think she had showed in her slide. Any data of blood utilization among COVID-19 and non-COVID-19 patients? Dr. Anju?
Like separately, I have not taken a data for the same. Like I've just included in a general way. Like it's everything was included in the study, like COVID and non-COVID.
Okay.
We are collecting the data for the same.
Okay, maybe in the next presentation. Can we call upon the next person, madam?
Yes.
Yes, you can call.
Dr. Rafi is the. Hello.
I think we are running out of time. Like, can you just post it in the chat box? Maybe she can answer to it. Dr. Amar, can you come on board?
Yes, sir. It will take just 1 minute. Respected chairpersons, faculty members, and dear doctors, I'm really thankful to the Young Professional Forum and Indian Society of Transfusion Medicine for allowing me to present on this platform. So this is a study of adverse transfusion reaction. It is a retrospective analysis of transfusion reaction at AIIMS Rishikesh. So I'll cover this presentation under these following headings. So what is an allergic adverse transfusion reaction? So it is the transfusion-related adverse event that occurs during or after the transfusion of whole blood or blood components or human-derived plasma products, or any undesirable response or effect in a patient temporarily associated with administration of blood or blood components. So this is a classification of transfusion reactions, just a basic outline. So on the basis of onset, the transfusion reactions are divided into acute and delayed. Acute transfusion reactions are acute hemolytic transfusion reaction, allergic transfusion reaction, febrile non-hemolytic transfusion reaction, transfusion-related acute lung injury, and in delayed hemolytic transfusion reaction and infections. On the basis of pathogenesis, we divide transfusion reaction into immune and non-immune. Immune contains FNSTR, DSTR, allergic transfusion reaction, TRALI, and non-immune contains transfusion-associated circulatory overload and metabolic derangements. So these many are the signs and symptoms which we observe in different transfusion reactions. So this is just a table outline showing the signs and symptoms for different types of transfusion reactions. So as you can see, for hemolytic transfusion reaction, we'll observe for cola-colored urine, fevers, hypertension, tachycardia, nausea, vomiting. For bacterial contamination, we'll look for the symptoms and signs of fever, chills, hypertension, nausea. And for transfusion-related acute lung injury, we'll look for the symptoms of dyspnea, fever, tachycardia, and obviously the changes in the X-ray, which will show pulmonary edema and decrease in oxygen saturation. For febrile non-hemolytic transfusion reactions, we'll look for fever, chills, rigors, and for allergic, we'll look for allergic signs and symptoms like pruritus, itching, urticaria, flushing, angioedema, and etc. So the basic management of transfusion reaction is we have to stop the transfusion immediately, and we have to keep the IV access patent for any IV fluid administration. And then we'll proceed for symptomatic treatment, and we send a post-transfusion sample and blood bag due to which the transfusion reaction has happened for transfusion reaction workup. And after the workup, we'll treat the reaction as per the cause. So this points, these are the important points which I've taken directly from Rossi. So in cases of recurrent febrile non-hemolytic transfusion reactions or any previous known case of febrile non-hemolytic transfusion reaction, the pre-medication with acetaminophen should always be used, and levofiltered blood bags should be advised. In cases of allergic transfusion reaction, treatment should always done with first generation antihistaminics. If repeated allergic reactions occur, then saline wash, platelets, and PRBC preparation should be advised, along with pre-medication if required. So all adverse transfusion reactions should be analyzed because recurrence could, so that recurrence could be prevented in the same patient in which transfusion reaction has happened, or steps could be taken for its further prevention. So the present study is conducted to analyze the prevalence of various transfusion reactions, management, and the associated factors. So all the transfusion reactions are to be reported under Hemovigilance Program of India, which was started in 2012. And the transfusion reactions are to be updated under the Hemovigilance software, which has been developed to collect and analyze the data related to the hemovigilance all over the country, which was developed by National Institute of Biologicals, which is situated in Noida, Uttar Pradesh. So the aim of the study is to analyze the transfusion reactions occurring in past 1 year at AIIMS Rishikesh. The primary objective is to study the number of cases showing the transfusion reaction and its further management, and to study the different type of transfusion reactions due to different components. For secondary objectives, we'll study about the blood group distribution, sex distribution, and age distribution. So this is a retrospective observational study done at the Department of Transfusion Medicine, AIIMS Rishikesh. All adverse transfusion reactions in past 1 year were taken up for study. Tables and bar graphs were designed compiling the data showing the results in terms of percentages and numbers respectively. So all cases for which transfusion reaction reports were received at Department of Transfusion Medicine from the hospital were included in this study. Exclusion criteria were none, and sources of data is transfusion reaction workup records, which we maintain at our Department of Transfusion Medicine in Rishikesh. So the total number of blood components which were issued in last 1 year is 24,100 approximately, and the total number of patients to whom these blood components were issued is 11,200 approximately. And from these, the total number of transfusion reaction observed is 39, and these are observed in 38 patients in total. So the total percentage of units associated with transfusion reaction came out to be 0.16%, and the prevalence of transfusion reaction among the patients transfused is 0.34%. So this is a graphical representation of the total issue. On the left side, we can see the total issue, and on the right side, we can see the transfusion reaction component wise. So from 10,532 RBCs issued, 27 RBCs were causing transfusion reactions. From 5,752 RDP issued, 10 RDPs caused transfusion reaction, and from 7,878 FFP issued, 2 FFP caused transfusion reaction. So this is the graphical representation of number of different transfusion reactions occurring due to different components. So in the first bar, we can see FNSTR, which is mostly due to PRBCs. And in the second bar, we can see allergic transfusion reaction, which is mostly due to RDPs followed by PRBC. And Transfusion-associated dyspnea is due to PRBCs. Transfusion-associated hypertension is due to one PRBC and one RDP each, and rest reactions occur due to PRBCs. So this is again a compiled result. So we can see in this study, the febrile non-hemolytic transfusion reaction is the most common reaction observed, which is almost equal to allergic transfusion reaction. The febrile hemolytic transfusion reaction is 41%. Allergic transfusion reaction was seen 38%. There was no delayed hemolytic transfusion reaction or delayed transfusion reaction seen. So this is age and sex distribution for the study. So this is the secondary objective. So we can see the maximum transfusion reaction was seen among 10 to 30 years of age group and 40 to 50 years of age group, and those were most common among males. This is a blood group distribution of transfusion reaction. It was most commonly seen among A positives and B positives, 33% each. So for the transfusion reaction workup of all these cases under the study, we did the clinical check of the requisition forms, cross-matching reports, labels of samples in blood bags, and no discrepancy was found in all these cases. This is the workup of samples and blood bag. So the color of plasma was clear in all these samples and blood bag. The volume of all the bags were recorded. There were no clots or leakage in any bags. The blood grouping was having no discrepancies. The direct antiglobulin tests were negative in all cases except two. One case of FNSTR, in which the pre-transfusion sample and post-transfusion sample both shows positive direct antiglobulin test, and one sample of transfusion-associated dyspnea, in which again the pre-transfusion post-transfusion sample both were positive for direct antiglobulin test. For indirect antiglobulin test, all cases were negative except one case of TAD, in which the results were mixed field in both pre and post-transfusion samples. The culture was sent for 12 bags, and all 12 bags were sterile. Result was sterile for all 12 bags. The repeat cross-matching were compatible for all pre-transfusion and post-transfusion samples. So how these cases were managed? All cases were managed conservatively. All antihistaminics and steroids were advised in cases of allergic transfusion reaction. Antipyretics were advised in cases of FNSTR, and there was one case of recurrent FNSTR for which leukofilter RBCs were advised and transfused. So imputability. The assessment of strength of relation of the transfusion reaction to the transfusion is imputability, and in this case 22 cases were probable and 17 cases out of 39 cases were possible. Coming on to discussion, this is a whole table showing the comparative study. So the present study is quite similar to Sovig et al, which was this study was conducted in Croatia, and it was conducted for the 12-year data was taken, and it was quite similar to the present study, because in this study too, the 49.5% FNSTR was common, and it was quite around the allergic transfusion reaction, which is again 49.5%. And for Areva et al study, which was conducted in Nigeria, the FNSTR was 65% and allergic was 27%. And for Kumar et al, which was conducted in Ames, Delhi, the most common reaction was allergic, and the second most common was FNSTR. The clinical elements among are the common causes which can cause adverse transfusion reaction. So there should always be a policy of checking the blood group and all the details of the bag which is issued at multiple levels by the technician, by the doctor, by the person who is issuing the blood, and finally by the nursing staff and the clinician who's going to transfuse the blood to the patient. So no clerical error was detected retrospectively among this study. A detailed workup of the patient's primary disease with proper history is also very important, because some diseases can mimic transfusion reactions like any other causes of hemolysis, like any drug which is causing hemolytic anemia, or any cause of pyrexia like sepsis, or any other cause of any respiratory distress. So finally, concluding my presentation, the total number of transfusion reaction observed were 39 in 38 patients, and the total percentage of units associated with transfusion reaction is 0.16. The most common acute adverse reaction to the blood components came out to be FNSTR followed by allergic. Although these reactions are less harmful, but fatal reaction can also happen. So preventive measures must always be taken, and the blood administration should always be supervised adequately. The limitations for the study is delayed reactions might be underreported due to a lack of follow-up, a lack of reporting, or these delayed reactions may mimic the concurrent comorbid illness, as I have explained earlier. The data may not be representative due to the ongoing COVID-19 pandemic. These many are my references. Thank you.
Open to discussion with chairpersons.
Yeah, Dr. Amarnath, it was a nice presentation. And I think as with Dr. Anju, the same can be said about most of our blood centers experience would be that the FNHTRs and the allergic reactions are more and more reported. And definitely there is underreporting, and we need to create a wave where the clinicians and the users, they are reporting the reactions back to us. Other than that, I think there is no comment from my side.
Thank you.
Dr. Amarnath, very well presented, and everything has been covered, and the observation that is made is almost the same in all the centers and all the institutions, and it is very well presented. And only two questions I have. You have said that in two cases, FFP, after transfusion of FFP, reaction has been reported. So I could not understand what were the reactions, those two reactions after FFP transfusion. So
this is the slide which is showing the reaction. One FNSTR was designated to one FFP and one allergic was designated to one FFP.
Achha, that
Yes,
means, so
yes,
in FFP transfusion, FNHTR, generally it is not seen. Na? I mean, this
yes,
is an interesting observation. One is FNHTR and allergic.
Yes,
so it's a very interesting observation that which is not
yes,
generally seen, or it is not reported also.
Yes, ma'am. Yes,
FFP, reactions due to FFP. And then second is A and B group, you said that the reactions are seen more frequently. That is also a very interesting observation.
Yes,
so, is there any study supporting that, or
ma'am, this is just a secondary objective which was covered under the study, ma'am.
Could you find any references regarding the association of blood groups with incidence of transfusion reactions?
Ma'am, I have to look into it. I have seen few studies. Ma'am, although the blood group prevalence in Uttarakhand is most common is B positive, followed by O positive and A positive, and the least common is AB positive. So that prevalence is also not matching with the result.
That will be interesting. Na? Then this will be the only study which will show. Otherwise, nowhere we have found any linking reaction, incidence of transfusion reactions